Hello, my name is Chris Wilson, and I'm a PGY1 pharmacy resident at Erlanger Health System, and I'm going to be talking about my research project, which focused on evaluating treatment of status epilepticus at our hospital. To begin, none of my preceptors and I have anything to disclose, and our objective is to describe trends in status epilepticus treatment and changes in practice that have resulted from implementation of a status order set. To go into a little bit of background about treatment of status, there are three main categories that therapies can fall into. All patients that present with status should receive at least emergent and urgent therapies, and these are listed below. The three most common urgent therapies are fosphenytoin, valproate, and levetiracetam. I've also listed some of the continuous infusions that are available for use in patients with refractory status. When it comes to initial management of status epilepticus, underdosing of benzodiazepines is very common. One of the most common doses I see is 2 milligrams of lorazepam, which is generally 50% of what's recommended in the guidelines. There's also a lack of evidence to prefer one specific urgent therapy over another, and there are some inconsistencies with dosing recommendations between guidelines and primary literature. A lot of these medications can cause harmful adverse effects, so optimal monitoring is vital for mitigating this. Things such as anti-epileptic drug levels, monitoring with labs, EKGs or vital signs, and continuous EEG monitoring, particularly for patients requiring continuous infusions, is necessary. Erlanger is a level 1 trauma center as well as a tertiary referral center, so we see a lot of patients that come into our emergency department, but we also see a fair amount of patients that present as transfers from outside hospitals as well. The purpose of our project was to improve our evidence-based treatment of status through the development of a standardized protocol, and we did this in collaboration with the neurology physician group at Erlanger. Our objectives were to compare AED usage, including place in therapy and dosage, before and after the implementation of the order set, and our secondary outcomes focused on monitoring, length of stay, intubation, and adverse events. Patients were identified via status epilepticus diagnosis code, and I've listed the dates of the protocol collection periods. You'll notice that in the post-protocol group, we're still collecting data. The date of December 19th was chosen because that was when the order set was implemented. We've also spent a great part of this year educating multiple provider groups that we identified as being high users. I list this just for reference, but this is the criteria that we used for appropriate dosing of the AEDs. We included all patients diagnosed with status, and I've also included our pertinent exclusion criteria for your reference here as well. Between the pre-protocol and post-protocol groups, there currently aren't any differences statistically between them. You will notice that the post-protocol group has a significantly less amount of people in it, and that's because, like I mentioned, we are still collecting that data. There are a large number of patients that present with a history of seizures, and so they are presenting with breakthrough seizures. We also have a large number of patients that come into the emergency department, but like I mentioned, we do get a fair amount of patients that come from outside hospitals. I mentioned the etiology mainly because we have a large number of patients that come in with an unknown or other etiology, and this is due to the retrospective nature of our study. In regards to our primary outcome, there is a statistical significant difference in the appropriate therapy selection. However, so far, there is not a statistical significant difference in the appropriate dose that was used. Further doing a subgroup analysis, looking at patients' first 3 therapies that they receive, you see across the board in the appropriate therapy selection that all patients are receiving a higher percentage of appropriate therapy. And when you look over to the right-sided bar graph, you see that we do have statistical significant differences in emergent therapy, which is typically a benzodiazepine, as well as in our refractory therapy. Further looking into our urgent therapy selection, you will see that there is a large amount of use of levetiracetam, and that's expected due to its ease of use and its availability in the emergency department, as well as it's considered to be relatively benign as well. I mention this because in our order set implementation, we focused on transitioning from a to a weight-based dose of levetiracetam. In regards to our secondary outcomes, we currently have one that is statistically significant different, and that is the continuous EEG utilization. Of note, in the pre-protocol group, we weren't able to utilize any continuous EEG monitoring. However, since we have hired a new epileptologist and we have been increasing our ability to use continuous EEG monitoring. I also want to make note of our intubation rate of 50% around that in both the pre-protocol and post-protocol groups, as well as our time on the ventilator of around a day and a half. I think those values are key when thinking about our area for improvement that I identified as being initial management. So if you compare our 50% intubation rate to that of the literature, it's around 20% higher, whereas in the literature you see rates of around 30%. I also think that we need to collect more post-protocol data before we make any definitive evaluations of how effective it's being, as well as determining how often it's being used in these patients. Also, I think that additional continuous EEG monitoring resources are needed for treatment of patients with continuous infusion AEDs, and that's something that we're currently working with neurology on. So our self-assessment question, which of the following is an effective strategy to improve adherence to evidence-based AED selection and dosing for treatment of status epilepticus? And the answer is C, implementation of a standardized protocol and provider education. These are my acknowledgements. And I've listed my email at the bottom of this slide, so feel free to contact me with any questions.